So let's look at joints. So joints are areas where bones come together, or it may be bone and a cartilage which comes together. They allow movement in most situations, but some areas you will find that no movement is allowed between joints. And obviously, in those areas where no movement is allowed, it is because you need to be more protective. You don't need movement to be occurring at that point. So up here you can see two bones here, and so this is the joint. In some joints you will notice there is a cavity, in some you don't. So let's look at how we classify joints. Remember, we always classify things in anatomy and physiology. So based on movement, when joints do not move at all, we call them synarthrosis or immovable joints. The word arthrosis, or just the word arth, anything with the word prefix arth has to do with joints. So arthrosis is a joint, and syn means together. So arthrosis, the word arth has to do with joints. So syn means together. So here are joints which are together, so they don't allow movement. A second type of joint which is partially movable. Some amount of movement is possible. Such a joint is known as amphiarthrosis. And then we have joints which are freely movable. All types of movements are possible at this joint, and that kind of a joint is called diarthrosis. Then based on structure, that means, so this was kind of functional classification. This was like a functional classification whether there was movement or not. And this is what is structural classification. What is there between the two bones which are coming together. So it's based on intervening substance, the substance which is present between the two or more bones. We have fibrous joints where fibrous tissue intervenes between two substances. So if we have one bone over here, let's say like a skull bone, which is a typical example of a fibrous joint, and then we have the other bone up here. So in this gap between the two bones, we have fibrous tissue intervening. So this kind of a joint is known as a fibrous joint. Joints where cartilage intervenes between the two bones, and the cartilage could be either hyaline cartilage or it could be fibrocartilage, and we'll see that we'll further classify cartilaginous joints. So where cartilage intervenes, we call it a cartilaginous joint. That could have either hyaline and fibrocartilage, and we'll see when we go further into cartilaginous joints, there's a subdivision. And then we have joints where there is a membrane and a cavity in that joint. The cavity is called the synovial cavity, and there is a membrane present between the two bones. So imagine if this is one bone and this is another bone. Here is the cavity between the two joints, and we have a membrane present, and this membrane covers the non-articular surfaces. That means the parts where no movement is occurring. So this membrane secretes fluid, and that fluid is called synovial fluid. So such a joint is known as a synovial joint. So this is a structural classification, this is a functional classification. And we usually kind of can add both together, and we'll see as we go along how we can add both structure and function together, and so we can say that one type of joint structurally is like this, but functionally is this way. So as we go along, you'll see. So let's look at the first structural classification, fibrous joint. So fibrous tissue intervenes between the bones, and it is divided into three types. The first is called a suture. And you all, when we did the first lecture introduction, remember we said something like a sagittal plane and a coronal plane, and we at that time said these planes are named, they got their initial name based on which suture they were either passing through or they were perpendicular to that suture. So a suture is seen in the skull, and here are three bones which are shown. So this is 1, 2, and 3. And in between them, this joint is called a fibrous joint because fibrous tissue intervenes between these bones and keeps the two bones together. So So sutures are seen between cranial bones and between your facial bones as well. A second type of joint is seen at the inferior, or also known as the distal tibiofibular joint, where the tibia and fibula articulate with each other distally. Here we have a ligament present getting the two bones together. This kind of a ligament is known as an interosseous ligament. Interosseous. Osseous is bone, inter between. So between two bones. So interosseous ligament. So it's keeping these two bones together. Usually this joint, syndesmosis, the inferior tibiofibular or distal tibiofibular is the best example. It also happens to be close to a synovial joint, because just below here is the ankle joint. But otherwise, by definition, this interosseous ligament, remember ligaments were made of fibrous tissue. So here again, fibrous tissue is holding the two bones together. A third type of joint is called a gomphosis, which is a peg and a socket type of joint. So here we have a socket, which is the socket for your tooth. And then here's the tooth, which kind of goes into that socket. And holding the tooth to this socket below is this tiny threads of a ligament, which is called the periodontal ligament. So these tiny strands of fibers hold the tooth in place. In fact, when you remove your tooth, when you have a tooth extraction, and if you've ever had the courage to look at your tooth after it's been extracted, you will notice at the root, you get these tiny little little things sticking out. Part of them are this periodontal ligament. Okay? So these are the three sub-varieties of a fibrous joint. Now, do you think movement is possible in fibrous joints based on what I've told you right now? Do you think movement is possible at these joints? You need to come up here and take these. No, think of it in your skull. Do your skull bones move? They don't move. You don't need them to move, because if they did, then you would not be protecting your brain. You need this to be a hard, immovable structure so that your soft brain inside can be protected. Think also as gomphosis. Think where your teeth are within their sockets. Do you find your teeth moving when you're chewing? You never feel your tooth moving. When you do feel it moving, it's about to come out, right? So fibrous joints do not allow movement in most situations. So fibrous joints based on movement, we can also call fibrous joints synarthrosis, because synarthrosis were joints which did not allow movement. However, here's something that you do need to know. This tibiofibular joint, the distal tibiofibular joint, this fibula is a very, very thin, slender bone made mainly for attachment of muscles. It doesn't participate in the knee joint, but participates in the ankle joint. So if you were to jump from a height, this fibula is so slender and narrow that if these two bones did not splay away, they did not move slightly away so that they dissipate some of that weight, this bone would snap very easily. So at this distal tibiofibular joint, very, very slight movement is possible. Very slight movement. And that movement is a gentle splaying of the two bones. By splaying means they just move apart slightly so that they allow the weight to kind of just, dissipate down below. And that prevents this fracture of this bone. And that also happens only when you jump from a height down below, not when you're just walking. So very, very slight movement. So that's why for all practical purposes, no movement is possible. Same with your teeth in their socket. The teeth, when you masticate, that means when you chew, there is a very, very slight movement that is occurring within this socket where the bone kind of almost like a little rotation which is occurring. This is an imperceptible movement. You cannot feel this movement. When you start feeling that your tooth moving, that is when part of the periodontal ligament has come out and the tooth is ready to fall out. But this allows little bit of very, very slight movement that does occur. So I want you to know that this movement occurs. It's not something that you can feel, but it's very, very slight movement. So therefore, for all practical purposes in fibrous joints, that's why we say that no movement is possible, and we call them synarthrosis. Because where it's possible, like in this situation and this situation, the movement is so very slight. Okay? Let's look at the next type of joint, which is cartilaginous joint. And remember, I said cartilaginous joints were where you had either hyaline cartilage or you had fibrocartilage intervening between the two bones. So we divide cartilaginous joints into two types. One is called primary and one is called secondary cartilaginous joints. In primary, it's hyaline cartilage, which is in the intervening cartilage. In secondary, which we'll see in a subsequent slide, it's fibrocartilage which is intervening. So let's look at this first one, which is called the primary cartilaginous joint. This is where hyaline cartilage intervenes between the two bones. So intervening means it's present in between. Intervene means to be present in between. So it's present in between the two bones. So look at this example. This is between the epiphysis in a young child, between the epiphysis above and the diaphysis below here, or it could even be at the lower end. So if I take the complete humerus, so it could be between the lower epiphysis and the diaphysis. So in between the two, remember, in a growing bone, you have a piece of cartilage which is called the epiphyseal plate or the growth plate. So this is hyaline cartilage, if you remember. So this cartilage is present between the epiphysis and the diaphysis. This cartilage is present between the epiphysis and the diaphysis. So here you can see, because what is by definition, what is a joint? Where two bones come together and are separated by something, either fibrous cartilage or fibrous tissue, cartilage or synovial membrane. So here we have cartilage present. So here is a joint which is present up here. So this joint over here is a primary cartilaginous joint, because between these two bones we have this piece of hyaline cartilage which is present. Okay, the hyaline cartilage does disappear when the bone completely ossifies and takes over the cartilage. So this is one example between the joints between the epiphysis and the diaphysis. Another example is where the first rib articulates with the sternum. Between the first rib and the sternum is this piece of cartilage which is called the costal cartilage, and this costal cartilage also in most cases ossifies. So therefore this whole first rib is attached to the sternum and it moves as one piece. Here also notice this is going to be replaced by bone. So therefore such joints are also joints where no movement is possible, and this is therefore also called a primary cartilaginous joint, is also called a synarthrosis. Based on movement, it's also called synarthrosis, because synarthrosis was syn meaning joints coming together, no movement is possible, and because it is a region where cartilage is present, and then that cartilage disappears and the bones fuse. That's why this joint has another name. It's also known as synchondrosis. Chondra for cartilage, syn means together. So the bones come together replacing the cartilage, right? So here, for example, the bones will come together and the cartilage will disappear. Here also, as I said, the cartilage gets ossified, so this whole thing becomes like one piece. So this primary cartilaginous joint is called a synchondrosis as well, based on how it will finally shape up. And it's called a synarthrosis because no movement is possible at this joint. Now, do you think these primary cartilaginous joints, like the one between the epiphysis and the diaphysis, are they permanent joints or are they temporary joints? By this I mean that do you see this joint throughout life, or do you see this joint only for a certain period of your life and then after that there is no joint? So that's what is meant by temporary or permanent. Okay, the correct answer is these are temporary joints. Here's where you have to use critical thinking. I said a permanent joint is where the joint is always going to be present. A temporary joint is where the joint is going to remain for some time and after some time there's going to be no joint. You know from when you did the skeletal system that this epiphyseal plate is temporary hyaline cartilage. See, it says it here. That's why looking at an image is so important. This cartilage is replaced by bone, and what happens? All of this becomes bone. So now it is one bone. There is no joint at all in this part, right? So therefore it's a temporary joint. So this kind of a joint, this kind of a primary cartilaginous joint where this whole thing becomes bone is a temporary joint. It doesn't remain throughout life. Let's look at the second type of cartilaginous joint. This one is a permanent joint. That means you will see this joint throughout life. There'll always be cartilage present between the bones. This is called a secondary cartilaginous joint, where fibrocartilage separates the bones. These joints are also known as symphysis. These joints are also called symphysis or also known as symphysial joints. And functionally they allow some movement. Functionally they allow some movement, therefore they are known as amphiarthrosis. Because by movement, synarthrosis was no movement. Amphiarthrosis was some movement. And diarthrosis was freely movable. Now these joints allow some degree of movement, so this is called amphiarthrosis. So what do I mean by this statement that fibrocartilage separates the bones but articular cartilage lines the bone surfaces? When we did cartilage, if you remember, we saw that articular cartilage was lining the ends of long bones. So see up here, this is the humerus, this is the head of the humerus, this will articulate with the scapula. So here's the scapula. And so articular cartilage is lining this head of the humerus. It will also line this glenoid cavity of the scapula so that the two bones don't rub. It's not bone rubbing against bone, but this soft cartilage which is kind of allowing movement and to rub against each other. So similarly up here in a secondary cartilaginous joint, because some movement is allowed, you have two bones. So let's take... So we have an example. Let me take the example of the intervertebral joint, the joint between the bodies of the vertebrae. So imagine this is the body of the vertebra above, this is the body of the vertebra below. This lining the surfaces of these two bodies up here is hyaline cartilage, which is called articular cartilage. So up here is hyaline articular cartilage. But the main intervening substance between these two bones is this intervertebral disc. This intervertebral disc is made of fibrocartilage. So here you can see the intervertebral disc, which is fibrocartilaginous in nature. Remember when we did tissues, an example of fibrocartilage was intervertebral disc. So here's this intervertebral disc, fibrocartilage, which is intervening between the two bones. But the bones are just covered on the surface by articular cartilage. All bones, wherever there is movement, they will have articular cartilage covering their surface. So these two bones also have that. These kind of joints, the secondary cartilaginous joints, are seen in the midline of the body. So if you look at a skeleton, posteriorly right in the midline are these intervertebral joints. That means the joints between the various vertebrae. So you can see that's in the midline of your body. So right up here at the back is the vertebral column. So the intervertebral joints are midline joints. Then here are the ribs which come around, and in front you have the sternum. And remember, the sternum was in 3 pieces, right? We saw the sternum was in 3 pieces. The manubrium, the body, and the xiphoid process. In between the manubrium and the body, again, is fibrocartilage. In between the body and the xiphoid process is fibrocartilage, with of course articular cartilage covering this part and this part. So this again is in the midline. So can you see this is in the midline anteriorly. And down below here, between the 2 hip bones, in front, this area is called the pubic symphysis. So here also this is fibrocartilage, and hyaline cartilage will just cover the ends of the 2 hip bones. So therefore, a good way to remember it is the joints, the midline joints of the body. The intervertebral joints, the pubic symphysis, which is shown here, and the intervertebral shown here, and also between the 3 parts of the sternum. So you have the manubriosternal and the xiphisternal joint. Slight movement is allowed at these joints. You know, in the vertebra, for example, you can bend forwards and bend backwards. You can bend to the side. Similarly, in the thorax, there is movement allowed between the manubrium and the xiphoid process. Manubrium and the body of the sternum, especially when you're breathing. During inspiration, the sternum moves forward to increase the volume of the thoracic cage, and then it comes back to its normal position. Between the pubic symphysis, this movement is possible, and especially during childbirth. When a woman gets pregnant, she releases a hormone called relaxin, which makes all the ligaments a little relaxed, and during childbirth there is a slight degree of separation between the pubic symphysis, just allowing the birth canal to get a bit larger. So slight movement is allowed at secondary cartilaginous joints. That's why we call them amphiarthrosis. Then we come to synovial joints. So these joints are there where there is a cavity. So far we saw in fibrous and cartilaginous, there was no joint cavity present. Instead, that intervening substance completely filled the space between the 2 bones. In synovial joints, where the 2 or more bones come together, we have a cavity which is present, which is known as the synovial cavity. It has fluid called synovial fluid. And there is this membrane which covers the non-articular parts of the 2 bones, because the articular areas, that means the areas which are going to come close to each other and move against each other, those articular areas are covered by articular cartilage. So here you can see, here is the articular cartilage. This part on the side and this part on the side is the non-articular area. So here we have the synovial membrane, which is a very, very thin membrane, very similar to your pleural, pericardial and peritoneal, which are extremely thin membranes. So here is this membrane which secretes synovial fluid, and that flows into the joint cavity. Synovial joints are usually very freely movable. So that's why we call these joints diarthrosis, because most synovial joints allow great degree of movement. So they are diarthrotic or freely movable joints. So to allow for no friction, you don't want friction between the moving bones. So that's why you have this fluid which is present here. And this acts as a lubricant. So it lubricates that joint and allows free, frictionless movement. Now this membrane is very, very thin. So if it was just this membrane which was attaching the 2 bones together and movement occurred, the membrane would be torn very easily, right? So you need something to strengthen it. So on the outside of the membrane, we have a thick fibrous capsule which is present, which may also be known as the articular capsule. Articular means to do with the joint. So on the outside of this synovial membrane, or in other words, the synovial membrane is lining the inside of this articular capsule. So here we have this articular capsule which covers the whole joint on the outside. This is a section, but if it was not a section, we would see that this capsule would cover the joint all around. So it will completely cover the joint all around, and then lining the inside of this capsule will be this synovial membrane. So in a cross section you can see it lining the inside of this articular capsule. To further strengthen the capsule in many synovial joints, you will also find ligaments. Ligaments attach bone to bone. So here you can see these ligaments which are present. So very often you will find these ligaments. Sometimes they may be part of the joint itself. So they may be part of the fibrous capsule itself, in which case we call them intrinsic ligaments. Sometimes we may find ligaments which are lying within the joint cavity. So they don't have anything to do with the capsule. So we call them extrinsic ligaments. So it doesn't matter. It could be either part of the capsule or it could be separate. But ligaments are fibrous structures which hold one bone with the other. So again, they help to strengthen the joint. They give protection to the joint and they strengthen it. They prevent the bones from coming apart. In some synovial joints, for example, the knee is one. You also have in the wrist. Wrist is another. The sternoclavicular joint is another. In some synovial joints, within the joint cavity, you may have fibrocartilaginous discs. So these discs are made of fibrocartilage. So for example, in the knee, we have a disc which is present right in the inside the joint cavity like this. So in a section, this is what it looks like. So it kind of divides the joint cavity into two parts. In most cases, in the knee, these discs are known as menisci. Only in the knee we call them menisci. And you may have heard of football players and soccer players tearing their medial meniscus or lateral meniscus. Usually the medial meniscus is torn. So wherever these discs are present, the purpose of these discs is they usually sort of enhance the joint cavity in such a way that they allow for articulation to occur better. So for example, let's take the knee joint. So here is the femur. So this is what the lower end of the femur looks like. And the upper end of the tibia is somewhat like this. So can you see that this part is kind of so rounded, whereas the tibial plateau or the surface of the tibia is more or less flat. You want to round up the lower end so that it can receive this rounded end of the femur. So here if we had an articular disc present which was like this, can you see how it's going to deepen the socket? And it's going to facilitate this articulating much better. So therefore we find these fibrocartilaginous discs in joints where they help to make the two bones articulate better. They also help in the spread of synovial fluid. They help the synovial fluid to spread. And in the knee, especially in the knee, they act as shock absorbers because the knee is like a weight-bearing joint. So here you have this tough fibrocartilage which acts like a shock absorber. So these are some functions of articular discs that you see in various joints. And it's only in the knee that you call them menisci. In the other areas like the wrist or the sternoclavicular, you just call them an articular disc. And they are fibrocartilaginous in nature. Then many synovial joints tend to have fat around the joint. These are like little pads. Again, this is usually to prevent friction, where bone comes against each other, or maybe there's a tendon very close to the bone, so it prevents friction. It allows like a little cushion over there. And then we have fluid-filled cavities. These are very similar to this synovial cavity here. So imagine you had a similar kind of cavity, but it may or may not communicate with the main joint cavity. So imagine you have a little cavity which goes outside and comes here. Or you may just have a cavity on the outside like this. So they are very similar to synovial cavities. In other words, they are composed of a thin membrane and they have synovial fluid inside. They may or may not communicate with the main joint cavity. So such fluid-filled cavities surrounding synovial joints are known as bursae. So bursae are fluid-filled cavities which surround a synovial joint. Again, their purpose is to prevent friction, and they may or may not communicate with the main joint cavity. And they prevent friction because imagine if there's a ligament, if there's a muscle and sorry, not a ligament, if there's a muscle present here and there is this tendon. Now this tendon is very close to bone. If this bursa was not present, every time this muscle and its tendon were acting, it would rub against bone and the tendon would get worn off. But now if you put this little cushion there, this tendon is not directly against bone, so it acts like a cushion, so it prevents friction, right? So that's the purpose, lubrication and preventing friction. Synovial joints are particularly well supplied. All joints have a blood supply and a nerve supply, but synovial joints are particularly well supplied with nerves and blood vessels. So let's take a look. You looked at that image there. So read these statements properly and see which of these statements is incorrect. Okay, the correct answer is this one. The synovial membrane is not present on the outside of the articular capsule. It is on the inside. If it was on the outside, how would the fluid get inside? The ends of the long bones are cushioned by articular cartilage. So look at this picture here. And when we did cartilage, we talked at that time also that ends of long bones where they will articulate with one another, they will have articular cartilage. Look at this bone. This is one end of it. Look at this bone. This is the upper end. This is the lower end of this bone. Look at it. It has articular cartilage. This is the articular capsule or fibrous capsule. See where the synovial membrane is. It's lining the inside of this capsule. If it was lining the outside, if it was present here on the outside, the fluid would be outside the joint and you'd have a big swelling outside your joint. Nothing would be present inside the joint. So therefore, this is the correct answer, okay? So here is an example of menisci and some bursae, some communicating, some non-communicating with the synovial cavity. So this is the top of the tibia, and as I told you, the top of the tibia is more or less flat, and that is lined on the surface. It will have articular cartilage. And then sitting on top of that is this meniscus, which you can see here. So what it does is it's kind of a little more cup-shaped. It deepens the cavity, and it allows the femur now to articulate properly with the tibia. Plus it's really strong, so it acts like a shock absorber and helps to kind of spread the synovial fluid. So here is a case where this is the shoulder joint. So on the outside of the shoulder joint, this would all be the fibrous capsule. All of this up here would be the fibrous capsule, which will be protecting it from the outside and keeping the bones together. It might have ligaments and other things. So you won't be able to see anything. Now imagine if I cut through and remove this fibrous capsule. Then I see this synovial membrane lining the inside of the fibrous capsule. And you can see this up here, very thin. And here, in some cases, notice how it's kind of going out and forming a little sort of projection where it's forming this bursa. Here it's also coming around a tendon and so forming a little sheath around the tendon. Some instances you will find that there is a bursa present here because there's a muscle which kind of comes out like that. So this bursa is present here. This bursa, notice how it's communicating with the synovial cavity, but this one here is not communicating. So not always do you have bursa communicating with the synovial cavity. Whether they communicate or they don't, they are still filled with synovial fluid, and the purpose is the same, to cushion and allow frictionless movement to cushion the area, because usually a tendon will come very close to bone, or maybe sometimes it might be a ligament coming very close to bone, and you want to just cushion and prevent friction in that area. Yeah. Yes, when you have a situation called bursitis, it is that area, the synovial membrane is inflamed. Any inflamed tissue which secretes tends to produce more. So there's more secretion, so this whole thing swells up, and because the capsule kind of keeps it, to, it can't stretch beyond, that becomes very, very painful. Yeah. It may, bursae may or may not communicate with the synovial cavity. So let's now look at, so we did joints, and we saw synovial joints, and these are joints which were diarthrotic. They allowed movement to occur. There are basically three types of movement that we talk about. The first type of movement is called flexion extension. Flexion is a bending movement where the angle between the two bones decreases. Or another definition for flexion and extension is where the two ventral surfaces come together. So let me do one thing. Let me go to this and we'll come back there. So the three types of movement. The first type is flexion extension. So flexion is where the angle between the bones forming that joint decreases, or two ventral surfaces come close to each other. That's called flexion. So for example, if this person was to lift their arm up like this, or here where you notice the knee, where you're flexing your knee. So notice this part, the angle between the two bones is coming close to each other. And here, if you lifted the arm up, like you flex your elbow this way, so here the two ventral surfaces are coming close to each other, plus the angle between the bones decreases. One thing to remember is that the ventral surface in the case of the lower limb, the back of the calf or the calf area, this is the ventral surface and this is the dorsal surface. And the lower half of the thigh is also called the ventral surface. So that's why we see in the case of when you do flexion of the elbow, the flexion is occurring this way, right? When you do flexion of the knee, it's kind of occurring in the posterior direction. So that's because the ventral surfaces are different. In your upper limb, the front of your arm and the front of your forearm are the ventral surfaces. But in your lower limb, the back of your calf, this calf area, and the lower part of the back of the thigh is the ventral surface. So that's how this is flexion and then this is flexion. Extension is the opposite movement where the bones go away from each other or the angle increases. Second type of movement is abduction and adduction. Abduction is going away from the midline. So when you take the limb away from the midline or the part away from the midline, that's abduction. And maybe the way you can remember it is, when someone abducts, they take you away. So, like that way. Adduction, what happens? When you add together, right? So adduction is coming together. So adduction is a movement where you bring, say in the case of the upper limb, taking your arm away from the midline would be abduction. Bringing your arm closer to the midline is not known as adduction. So that's the second type of movement. The third type of movement is called rotation. So rotation, it's like, imagine you pivot, like how a ballet dancer pivots, pirouettes. That's rotation. So we have medial rotation, also known as internal rotation, and lateral rotation, which is also called external rotation. So medial rotation is that, imagine if this on the humerus, this is the anterior surface of the humerus. So where its anterior surface starts facing inwards or medially, so it rotates towards the midline like this. And lateral rotation is where it rotates towards the outside. And if you'll all put your hand on, not on the tip of your shoulder, but on the front of your shoulder up here, right in the front. And you can feel this lesser tubercle, right? And now rotate your arm medially, can you feel this lesser tubercle moving? And rotate it laterally, you can feel this lesser tubercle moving. So in medial rotation or internal rotation, it's moving inwards. In external rotation, it's moving outwards, okay? So this is rotation. So these are the three types of movement. You will often notice a movement called circumduction mentioned. Circumduction. Circumduction is not a movement by itself. Circumduct means to go in a circle. Circumduction is a combination of movements. So for example, when you pitch a ball like this, when you throw a ball like this, what you're really doing at the shoulder, you're doing extension, then you're doing abduction, and you're also doing lateral rotation. Then you come in front, you're doing flexion and medial rotation, and you come down and you're doing adduction. So you can see it's a combination of movement. So circumduction is not a movement by itself. Now let's go back to this picture. So knowing what these movements are, movements occur along an axis. So flexion and extension occurs along a transverse axis. So imagine if you put a pin through the shoulder, or if you put a pin through your elbow and the pin is going across transversely. So imagine if you've got your elbow, here's the humerus, this is the ulna, and here's the radius. And let's say you take a pin across like this. So this is a transverse axis. When these bones move up and go closer to the humerus like this, this is flexion. And when they move away, that's extension. Can you see? So along a transverse axis is where flexion and extension occurs. Same with your wrist. So notice at your wrist, imagine if you put a pin right through your wrist like this. This is flexion, this is extension occurring on either side of the axis, right? Abduction and adduction occur along an anteroposterior axis. That means going from front to back. So notice up here, going from front to back, anteroposterior axis. So notice this, abduction is on this side of the axis going away from the median plane. Adduction is when you bring it closer to the median plane. So imagine a pin going across. So this is abduction, this is adduction. So you can see it's on either side of the axis. Rotation is along a vertical axis. So it kind of rotates inwardly or outwardly. So you call it medial or lateral rotation. Okay? So let's take a look at these movements. Now, she uses a different term, but I want you to kind of pay attention to the axis and notice how these movements occur.
About an axis. There are three axes that we will be discussing. The frontal horizontal axis.
Okay, so this one, which is going across, so notice this is a transverse axis. This, which is going across this way, is an anteroposterior axis, going from anterior to posterior, okay? This is an anteroposterior axis. And this one coming straight down is a vertical axis. So she just uses different terms, but I just still want you to see transverse axis, anteroposterior, vertical.
The sagittal horizontal axis and the vertical axis. When a person is walking, that individual is moving in the sagittal plane. It can be also described as moving about a frontal horizontal.
So notice when in flexion extension, it's occurring along a transverse axis. So see this going across like this, transverse axis.
Axis. Other examples of moving in the sagittal plane about a frontal horizontal axis would be performing a squat or even a leg raise.
See that? Everywhere it's transverse.
Can be classified as either extension or flexion. A person is performing jumping jacks. They're moving in the front.
So again, this is anteroposterior axis. So you're either moving away as an abduction or moving towards as an adduction.
Frontal plane about a sagittal horizontal axis. Other examples of moving in the frontal plane about a sagittal horizontal axis would be a cartwheel or working the adductor muscles of the inner thigh. These movements can be described as either abduction or adduction. The last axis left to discuss is moving in a horizontal plane about a vertical axis. If an ice skater spins, they are moving in a horizontal plane about a vertical axis. Other examples may be shaking your head no, or twisting the spine while the feet are planted on the ground. Moving in the vertical axis requires rotational movements. To recap, flexion.
So you see these three axes and the movements which are possible. So now let's answer this question. So when you stand at ease with your legs apart, what is this an example of? Abduction, yes, this is a case of abduction, not extension. Extension would be different. Here a person is standing like this, away from the midline. Okay. Is abducting their upper limbs as well. So this is abduction. Yeah. Standing at attention would be adduction. So that would be the opposite. There are, apart from these three types of movements that I told you, flexion, extension, adduction, abduction, and rotation, internal and external, there are certain other movements which are only seen in some areas, or they're given names only in some areas. There is one movement which occurs in the forearm. It just occurs in the forearm. And this is where the radius moves over the ulna. So it's a rotatory movement. The radius rotates over the ulna, and this is done when you take your limb in such a way that your palm looks down, like here, your palm looks down or backwards. So your radius is rotating over the ulna. This movement is known as pronation. When you do it the opposite movement, where you bring your forearm back to its original position, where either the palm is looking up or the palm is facing forward, that movement is called supination. So this occurs in the forearm at a joint which is called the radio-ulnar joint. That means between the radius and the ulna, because the radius moves over the ulna. So this occurs at the radio-ulnar joints, pronation and supination. It's a rotation. The radius at its upper end rotates within a ligament attached to the ulna during pronation, and during supination it rotates and comes back, so the two bones lie parallel to each other. In the ankle, instead of using the word flexion and extension, in the ankle, instead of using flexion and extension, we use the terms dorsiflexion and plantar flexion. So dorsiflexion is truly extension at the ankle joint. Dorsiflexion is truly extension at the ankle joint, and plantar flexion is truly flexion at the ankle joint. But instead of calling it extension and flexion, we call it dorsiflexion and plantar flexion. And the reason for this, the reason we kind of look at it this way is because by definition, by anatomical definition, flexion is where two ventral surfaces come close to each other, right? And extension is where they move away from each other. Now, during fetal life, what happened is that the limbs kind of developed. So the upper limbs developed as small little buds on the side, and the lower limbs developed as little buds on the side like this. So imagine this was a fetus. So the upper limb buds here and the lower limb buds here. The upper limb buds moved on and became the whole hand like that. So they kind of grew this way and they came down by the side, and so the ventral surface still faced anteriorly and the dorsal surface still faced posteriorly. In the case of the lower limb, what happened is as these buds were developing, they underwent a little bit of rotation about mid-thigh. So when they rotated mid-thigh, imagine this was the ventral surface. Now, because of rotation, the ventral surface faced back and then they developed. So that's why when you do flexion, can you see that the ventral surface is actually facing at the back? So this actually rotated, you know, they kind of, I don't know how to draw it, but they kind of rotated like that. See that way? They kind of rotated, so the ventral surface went back. So that is the anatomical definition of ventral surface and also of flexion extension. But embryologists, what they said is that the fetus is in a state of complete flexion. So when the fetus is inside the uterus, it's completely flexed. So it's flexed like this. So its lower limbs are all flexed and its upper limbs are also flexed like this. Completely kind of squished up like that. So it's at its ankle also, it's this way. It's kind of gone this way. So by embryological definition, this kind of thing would be flexion, but by anatomical definition, it is not flexion because these are not ventral surfaces coming close to each other. So therefore, to satisfy both embryologists and anatomists, they started using the word dorsiflexion to say that the dorsal surfaces are coming close to each other, and plantarflexion to say that the plantar surfaces are coming close to each other. But this is truly extension, so therefore when you do the muscular system, you will see that the muscles which are crossing and coming to the dorsum of the foot all have the word extensor in front of them. Okay? So that's why it's called dorsiflexion and plantarflexion, and that occurs at the ankle joint. Then in the foot, yes?
What is it for your hand?
In the hand, it's called normal flexion and extension because in the upper limb, it behaved in a normal manner. So we don't use anything. We just say flexion of the wrist and extension of the wrist. Okay. In the lower limb, there is a movement which occurs, and the movement occurs at the joints between the tarsal bones. That movement is called inversion and eversion. So inversion is where, imagine you are standing on the lateral border of your foot so that your soles face each other. Have you ever noticed little children kind of trying to do that? They stand like this, you know, they just turn their, stand on the lateral border of the foot and the soles face each other. And eversion is something that happens when you walk on an uneven ground and you stand on you by mistake sort of put your foot on a stone and your foot twists in such a way like this so that the soles face away from each other, where you are now standing on your medial border. So eversion is where the soles face away from each other, like is shown here. And inversion is where the soles face towards each other. And that movement, remember, does not occur at the ankle but occurs at the tarsal joint. At the ankle, you can only do dorsiflexion and plantarflexion. So now let's describe the synovial joints. So all this while we talked about axis. So we said either there was a transverse axis or an anteroposterior or a vertical axis. But there are a few synovial joints where there is no typical movement like flexion, extension, abduction, adduction or rotation occurring. Instead, there's a simple gliding movement. So the bones just gently glide against each other. So therefore, such joints are known as non-axial joints. So no axis is involved. It's just a gliding movement. The surfaces of the two bones are plane. They are flat. So that's why these joints are called plane synovial joints. The surfaces are flat. And examples are these tiny joints between the carpal bones, the joints between the tarsal bones, so intertarsal, even the joint between the acromion of the scapula and the clavicle. So this is called the acromioclavicular joint, which is there at the tip of your shoulder where the clavicle articulates with the scapula. So this joint also is a plane synovial joint. You just have a gentle gliding movement allowed between the two bones. So no axis, it's just gliding movement. Then we have joints which allow movement in one axis. So either they allow flexion and extension to occur, or they allow rotation to occur. We don't have a joint which just allows abduction, adduction to occur. So we only have these two types of uniaxial joint, one axis. So flexion, extension either which occurs in a transverse axis, or rotation which occurs in a vertical axis. So those joints which allow just flexion extension to occur act like a hinge, like a door hinge. So your elbow joint is a very good example. So you can just do flexion extension at the elbow. Your interphalangeal joint, IP stands for interphalangeal. That means the joints between the phalanges, these joints between the phalanges. All you can do is either bend your finger or straighten them out. Bend your finger or straighten them out. The knee and the ankle. At the knee and the ankle also you can do flexion, extension only. At the ankle you can do dorsiflexion or plantar flexion. The reason I have an asterisk against them is because these two are what are known as modified hinge joints. These are called modified hinge joints because in the knee joint, in certain positions you can do a bit of rotation. Only in certain positions you can do a bit of rotation. And also the movement is a bit more complicated in the knee. And in the ankle, when you dorsiflex your ankle, you cannot move your ankle at all side to side. It's like caught between the tibia and the fibula. But when you plantar flex your ankle, you can actually do a little bit of a side to side movement. So because again, in a certain position, you can do a little bit more. That's why they are called modified hinge joints. Just to say that a little bit more can be done with them. The second type of a uniaxial joint is called a pivot joint. The word pivot means to rotate. So this allows rotation, and we all know that rotation is along a vertical axis. One example is the radioulnar joints, the proximal and distal radioulnar joints. Proximal and distal radioulnar joints, or also called superior and inferior radioulnar joints. So this is also called superior and inferior radioulnar joints, which allowed that supination and pronation to occur. Remember, we just saw that movement, supination and pronation. It was a rotatory movement. Another pivot joint is the joint between the atlas, the first cervical vertebra, and the axis, the second cervical vertebra. So the atlas is a ring-shaped vertebra sitting on top of which is the skull. And then the axis sits below, and the axis has that little projection. What is the projection called? Dens, yes, dens. So when you do this movement of saying no or turning your neck or whole head side to side, the skull along with the atlas moves around the axis. So along the dens serves as a fulcrum, and the skull and the atlas rotate around it. So therefore, that joint is called, between the atlas and the axis, is known as atlantoaxial joint. So that allows rotation. So these are two examples of pivot joints. So everybody should be able to answer this. In which axis will movement occur in a pivot joint? Vertical axis, I just wrote it down. Vertical axis, because it's rotating, you're going around. Vertical axis. The next is are joints which allow movement in two axes. So they are called biaxial joints. The two axes that they allow movement are flexion and extension, which is along a transverse axis, and abduction, adduction, which is along an anteroposterior axis. These joints are called condyloid joints because they have the one surface which is kind of large and protruding, and another surface which is more like a socket. So that's kind of, this is the way it looks like, one large protruding surface, another one which receives it, so that's like a little bit of a socket. So this is called a condyloid joint. Your wrist joint and your metacarpophalangeal joints, that means the joint where your knuckles are. The metacarpophalangeal joint is this area here where your knuckles are, this part here. Metacarpophalangeal joints. These allow the movement of flexion, extension. So in your wrist, for example, you can do flexion, extension. You can also do adduction, which is where you take your hand towards the midline, and you can do abduction where you take your hand away from the midline, or which we can call this ulnar deviation or radial deviation. This movement where you kind of rotate your wrist, this is not a separate rotational movement. This is circumduction, because here you are doing extension, adduction, flexion, abduction. So this kind of thing which you are doing is not rotation. That's circumduction. So that's the wrist joint. Then at the metacarpophalangeal, which is where the knuckles are, for your hand, we don't take moving towards the midline as adduction and moving away from the midline as abduction. Instead, we take an imaginary line through the middle finger. So when you move towards the middle finger, that's called adduction. When you move away from the middle finger, that's called abduction. So when you spread your fingers out, that's abduction. When you get them together, that's adduction. So if you put your hand on your knuckles and then you spread them out, you can feel the movement. And you bring them together, you can feel the movement. You can do abduction, adduction, flexion, extension. So your metacarpophalangeal joints allow these two types of movements as well, along with the wrist. There is a modified type of biaxial joint, which is called a saddle joint, because it's based on the surface, so it looks like a saddle. One end is like this and the other end is kind of curved like this. So based on the way the bones are curved, it's called a saddle joint. This is the joint between the carpal and the first metacarpal. So it's a joint of the thumb. This allows, it's very similar, so it also allows flexion, extension, adduction, abduction. But there's a little bit of rotation which accompanies flexion and a little bit of rotation which accompanies extension. So that's why the range is a little bit more. So it's kind of not truly biaxial because it can do a little bit more, but it's not truly multi-axial because rotation is not separate. It kind of accompanies it. So it's very similar to a condyloid joint, just allowing a little bit more range. So that's the carpometacarpal joint of the thumb. Then lastly, we come to multi-axial joints, which allow all three types of movement. So they allow flexion, extension, abduction, adduction, and rotation. That means all three axes are covered. And the shoulder and hip are the best examples, and these have a socket and a ball. So that allows the movement. So it's called a ball and socket joints are multi-axial joints, and hip and shoulder are the best examples where you can do all these movements. So these are the most freely movable joints because you can do all of them. So remember what we talked about when we said bursae and what their function was. So where do you think you're most likely to have bursae? In relation to which of these joints? Ball and socket, yes. The purpose of bursae is to reduce friction. Where do you expect most friction? Where there is most movement. And ball and socket is where most movement occurs. So you'll see them most around the ball and socket type of joint. Which of these joints has the greatest degree of movement? And degree, I include range in this also. Ball and socket, yes, plane only allows gliding movement. Ball and socket allows all three types of movement. So you get most movement there. Let's look at a few joint conditions. I'm sure at some point or the other, many of you may have yourself or you may have heard of people tearing their ligaments. Such a thing is known as a sprain. A strain is where a muscle is torn or stretched. So sprain is to do with ligament, strain is to do with muscle. Ligament tearing takes longer to heal than even a bone fracture, because ligaments are made of fibrous tissue, and fibrous tissue is not well supplied with blood. Then when we come to joints, joints can either completely get out of alignment. So the two surfaces which were normally articulating with one another no longer articulate. Such a condition is known as a dislocation, as you can see up here. So look at the head of the humerus has completely come out of the glenoid cavity. So this is a dislocation. As opposed to that, we have something called subluxation. Subluxation is where the bones are still in contact with one another, but they are not aligned properly. So notice up here, this is how the bones should be. So this is how their proper alignment. Look at this case. This bone has moved further back, so it's not properly aligned. So while the contact is still there, the alignment is not there. So this is misalignment, and that is known as subluxation. Anything which inflames the joint, it can be autoimmune, it can be a disease of old age, that condition is known as arthritis. So sometimes people have rheumatoid arthritis, which is an autoimmune condition, or there may be a disease of old age, which is where because of wear and tear, the bones the articular cartilage disappears, the bones get rough and they rub against each other, and little small spicules of bone may be found in the joint cavity. So that's called osteoarthritis. So arthritis is inflammation. Itis means inflammation, and this is of the joint. And then we have a condition where sometimes seen in people, it used to happen a lot in in England, in the royal family, they drank a lot of wine, and wine has that substance which can deposit uric acid. And so uric acid crystals deposit in various joint cavities, and they inflame the joint, make it immovable, and these little sort of bits of uric acid form what are called crystals known as tophi, and that condition is known as gout. It usually tends to involve the big toe, and it involves the metatarso-phalangeal joint of the big toe. So that area becomes extremely swollen and big. So let's take a look at dislocation and subluxation to see the difference between the two.
With the humeral head displaced, subchoroidal or subglenoid.
So here you can see how the head of the humerus came completely out of the glenoid cavity. So this was dislocation. So I'm going to stop it here because he talks about the biceps and how that's affected. But you saw the head completely coming out, no alignment at all. And here we are looking at a case of vertebral subluxation. So notice here how this bone has subluxated. There's still alignment, but it's not proper alignment. So this is misalignment. So the bones are not completely out of alignment. So here notice how this bone is going to move backwards. So it's still showing some degree of touching, but not in the way it should be. So subluxation is a case where there is misalignment, whereas dislocation is where there is no alignment at all. Okay?